Are you sitting comfortably? My name is Dr. Henry Murphy. You may remember me from such public service announcements as Observation Bay, watch out, and Anaphylaxis, watch out. But today I'm here to talk to you today about back pain. So back pain has a very high prevalence in the UK. Back pain is the single largest cause of disability in the UK, and back pain alone, low back pain, accounts for 11% of disability of the UK population. And it affects around a third of the UK adult population every year, so huge numbers. Of that population of patients with low back pain, around 20% of those will see their GP for their symptoms, and a smaller percentage of that population will then come to the ED with acute back pain. Also, the reason we want to talk about this topic is because back pain is a huge area of litigation, and we'll talk about that later. So what we'll do is we'll talk about tips which will be useful for every case of back pain that you see here in ED at West Middlesex. And for clarification, we're talking about acute back pain, so not chronic back pain. These patients probably shouldn't be presenting to the ED, although sometimes they might. And sometimes they might present with a change in their symptoms, and that's different. It's the acute nature of the pain that we want to talk about today. So we're going to talk about the initial approach to these patients, histories, red flags in history examination, examinations, differential diagnoses and investigations. And we want to cover the different systems that are likely to cause pain in the back. So we want to think about anatomical planes and also the surgical sieve, and try and make sure that we don't miss any potential diagnoses. So you might have a lot of experience in managing back pain, and so we want to see if things that we do at West Middlesex are the same as what you would do from your own prior experience. So in terms of the way that I would approach a patient with back pain in the ED, they are attending with back pain. You're going to go to your GP if it's less severe, so they are going to need analgesia. And what I would normally try and do is base my analgesia on my suspicious or suspecting diagnosis. So if it's a muscular type of story, then I want to get in early with a benzodiazepine like diazepam, rather than an NSAID like a PR diclofenac for somebody who's got, say, suspecting renal colic diagnosis. That's going to then allow you to take a thorough history from the patient whilst the analgesia is starting to take effect. So in terms of a history, I find that the Socrates structure, so symptom onset, etc., is really helpful for any pain history. And I find that the history is most important to lead to confirming my diagnosis in the examination, rather than leading straight for investigations, which I don't think are really necessarily going to be helpful in every case of back pain. The history might tell you of how acute the event was, so was it sudden onset, so we're thinking maybe things like disc prolapse, AAA, or a subacute sort of history, so malignancy, infection, degeneration. And we're not going to be talking about fractures because there's a separate spinal fracture talk, so we won't cover that, but pathological fractures are part of this sort of non-traumatic back pain subgroup, and so that's definitely worth thinking about in the history. So you want to ask about all aspects of the past medical history. So is the patient, for example, an intravenous drug user? Because that will make you think a lot more differently about how they might present. They might present with a sort of subclinical infection like an abscess, which they might not mount an inflammatory response if they're immunosuppressed, for example. So that's really important. And then the occupation of the patient is really, really important. So what level of function are we aiming for to get this patient back to? Is their occupation or the playing of sports relevant to the underlying diagnosis? And like I said before, if a patient has chronic back pain but they're presented to the ED, ask why they've come today. Is there something new that's happened? Because try and remember that chronic pain patients can present with acute medical problems or surgical problems. So in terms of history with specifics to red flags within back pain, what we want to make sure is that we don't miss any concerning features that might raise our suspicions of a more serious diagnosis, because most patients presenting with back pain in the ED don't have a serious underlying condition, but there are some features of the history that we really need to not miss. So we're talking about loss of neurological function, which is severe, or bilateral sciatica. impairment of bladder, bowel or sexual functions. These are all neurological symptoms. Very, very severe pain. Pain in those who are already known to have osteoporosis, malignancy or are taking steroids because of the risk of pathological fractures. Patients at the extremes of age, so under 18 or over 50. Pain that's worse at night lying down or worse on coughing, sneezing or straining. Thoracic pain, which is quite unusual. Localized tenderness over the spine. Weight loss, fevers or night sweats, which makes you think about maybe an infection or even a malignancy. And then immunosuppressants, so HIV, diabetes, IVDU patients, recent chemotherapy or steroids, recent UTIs and tuberculosis as other risks of infection. So in terms of the examination, what you want to do is use this to rule out concerns about red flags or neurological symptoms, but also to confirm the diagnosis that you're suspecting. So if you're suspecting muscular spasm as the underlying diagnosis, then there should be some sort of palpable tense muscle that's localized and tender. And if that isn't there, then you should be questioning your diagnosis. What you want to be doing is examining the back in general. So are you thinking about the joints of the back? Are you thinking about the neurological system, the musculoskeletal system, the skin? And probably a bit of everything is necessary to try and confirm exactly where you think the problem is. And then if you're suspecting something like a disseminated infection or malignancy, then you need to do a generalized examination. So is there an abdominal mass, for example? Also, if you're thinking about something that's not sort of within that posterior compartment, are you thinking about something more anterior like a AAA, which is retroperitoneal, which can cause back pain? Then again, an abdominal examination or femoral pulses, that will be really relevant. So obviously use your history to guide your examination. There's a really good website called Geeky Medics, which is really good for honing down your examination skills, and it separates things out. So musculoskeletal is separate, say, from neurological. It's really good to have a look. There's a chart which you can Google, which is called the Asia chart, which we probably might mention in the spinal fractures talk as well, or the trauma talk. And that stands for American Spinal Injury Association. And it's a really good way of just mapping out the dermatomes for sensation, but also there's an area where you can document your rest of your neurological examination. So that's really useful if you need to remind yourself of exactly where L3 is, etc. In your examination, you might want to include some special tests to try and confirm or refute any red flag concerns you have. So does the patient need a post-void bladder scan to check for a residual volume? And then a PR, so per rectal examination, is normally indicated in back pain because not documenting that finding has been shown to be a real problem in litigation cases, and it's really important to make sure that the patient doesn't have any subclinical neurological symptoms they haven't noticed. Other concerning features in your general examination might be looking at the rest of the patient. Are there Kaposi sarcoma which make you think about HIV, etc.? So don't discount the benefit of a general examination. So in terms of diagnoses, it obviously depends on the history and the examination. You can think either anatomically about the diagnosis going sort of outside in, or you can think about the surgical sieve. So thinking anatomically, the skin, that's really important. Do a proper inspection in your examination. You can maybe confirm that there's vesicles of shingles strip, which might be the only diagnosis. I've seen that before here. Musculature going further in, so muscular spasm, you can confirm that on examination as well. Bones, so fractures, either traumatic or pathological. Tumours within the bone, sickle cell disease can present with back pain. And then intravertebral discs as well, so disc prolapses, disc bulge. Thinking about the spinal canal, so spinal stenosis. And then further back, thinking about an abdominal aortic aneurysm, renal angle pain, so renal stones, infection, infarction. Even bowel colic, so within the abdominal compartment, other things outside of that realm, so a lower lobe pneumonia can present with back pain or posterior pain. So there's lots of different things to think about. It's one way of trying to think about working out your differential diagnoses if the diagnosis isn't clear. And then the other way is using the surgical sieve, so infection, so thinking about abscesses within the spine, easy to misdiagnose, so patients might present just with a simple flu-like symptom, but their pain is in the back. If they have neurological symptoms, they definitely need imaging. Neoplasia, so pathological fractures, often missed, but also tumours within the spine, so progressive history, maybe additional features like weight loss or night sweats. Trauma will be covered by another talk. Vascular, so hematomas can cause pressure on the spinal cord or the cord equina. So there's lots of other diagnoses within the surgical sieve you could think about. That's another way of trying to categorise to make sure that you haven't missed anything in your history. Talking about a diagnosis that's definitely worth reading up about and also not missing is Aquinas Syndrome. So the Aquinas Syndrome is classified by the compression of the nerve bundles below the spinal cord, so below L2. And there's lots of different causes, so fractures, hematomas, abscesses, etc. And the reason that we want to talk about this is because urgent confirmation with MRI and urgent surgical decompression is really important to prevent permanent neurological damage. In terms of how important this is, the NHS gave out 23 million recently, that's a sort of yearly figure, in litigation costs. And then in terms of a review of 15 cases that were taken to court in America and were successfully litigated against, things that were more important in the likelihood of litigation were a delayed time to surgery, bladder and bowel symptoms that were present at presentation but maybe weren't picked up on or acted on, sexual dysfunction present at presentation, so that shows you how key that history is, a delayed time to being seen, delayed time to imaging, and the setting of the appointment, which maybe isn't relevant for us. None of those patients had a rectal examination, so that shows you how important it is to perform and document that examination. I've seen one case of Aquinas Syndrome in my career, and it was in a patient who was homeless who had chronic back pain. So it's very easy to dismiss these patients who present with chronic pain, especially if there's some other aspect of the social situation or the history that makes you think this patient might have presented for another reason, but that just shows you how important it is to take patients seriously and to do a proper examination. So in terms of investigations for back pain in general, I'd say it really obviously depends on the suspecting diagnosis, but a plain X-ray of the spine is not particularly useful, especially in somebody who's presenting without trauma or without suspicion of a pathological fracture. So I'd say if you're thinking about getting an urgent diagnosis of fracture or severe pain, neurological symptoms, etc., then a CT is probably a good first port of call rather than a plain film. It's probably worth discussing all of those cases with the registrar before you make any further calls to radiology. If you're thinking more about Aquinas Syndrome or a more subtle diagnosis like an abscess, then an MRI is probably more useful, and getting an MRI in hours and out of hours is quite challenging. So there are some emergency slots, but early contact with neurosurgery can help you advocate for trying to get an urgent MRI, either here or transferring the patient out to Charing Cross Hospital, which is the hospital that we would send patients to for neurosurgical investigations or surgery without trauma. So if the patient is discussed with neurosurgery, then there's a website called referrapatient.org that one of the registrars in charge can help you get on, and it's important to document that referral. You can call the registrar at the same time, but the referral needs to be documented on that website. And then also, if there is any imaging that's been done already, like a CT scan, then that needs to be transferred over so that the neurosurgeons at that hospital can see that referral. And that can be done at the radiology reception or with the radiographers via the IEP system. Obviously, if a patient's got some sort of neurosurgical ongoing plan, then they will have a plan of action, and Some of those patients might be eligible to go to OBS Bay. Normally, if a patient has been discussed with the neurosurgical team and there's a pending diagnosis of called Aquinas Syndrome, they should come in under a specialty team, and normally they're best looked after by the orthopaedic team. Sometimes if there's a diagnosis, say, of a spinal tumour, which is palliative, etc., then that patient might be best looked after by the medical team. I'd say if there's any doubt about who that patient should go under, maybe run that case through with the registrar in charge. If there's any patients who don't have any concern on examination and can be discharged, then I think it's worth giving them information about the red flag type symptoms we'd want them to look out for and when to return, because patients can progress and get worse. And I think that's probably everything I wanted to talk about. So in summary, a very good history and a thorough examination to try and confirm your suspicions and rule out concerning features should get you through this tricky area. And if in doubt, make sure that you ask for help.